Very good afternoon to respected seniors and fellow colleagues. I'm going to talk about stereotactic image-guided dacryolocalization in complex lacrimal surgery. So we'll be seeing how we can use stereotactic technology to visualize the lacrimal system. These are the financial disclosures of Dr. Muhammad Javed Ali. So for navigation guidance in endoscopic lacrimal surgeries, what we first need is the Stealth Station S7 system, which is present at the Authors Institute. This is the system which is going to provide the navigation to us. And the parts that we are going to visualize, the parts that we are interested in, have been marked in blue. These are the canalicular system, the lacrimal sac, the nasolacrimal duct. We are also going to see how the bony structures are related to them. So for visualizing the nasolacrimal duct system, we first need to have a 3D dacryocystogram, which we can see on the screen. So in the first image, which is present on the right side, we can see there's a white streaming lake on the right side going down up to the nose. But on the left side, it stops midway in between. So there's a blockage there. Then in the other image, we can see that the white part on the right side stops even before the nasolacrimal duct starts. So then in this case also there's a proximal blockage. So we need a 3D DCG, and all this data, all this patient data, we're going to feed into the system now. So the system provides us a 3D stereotactic reconstruction based on the patient specific images, and we can know the exact localization of the pathology, and the machine will give us all this in 3D view. Now we have to integrate navigation into these images. So the one on the right side lower image is the 3D view. The purple thing is the navigation probe, and the red is the lacrimal sac, which is our area of interest. So when we're touching the lacrimal sac with the purple probe, we can see in the axial, sagittal, and the coronal scans that the crosshairs, that the two green lines, they are coinciding at the exact location. So using navigation system, we can very accurately delineate the structure that we want to address. Now that we've integrated navigation into our images, we're going to see how it helps us in complex patients. So this is one patient in which navigation system was used for endoscopic lacrimal surgery. On the right side, you can see there's a bright white structure that is the lacrimal sac. And an interesting thing to note is that there's a very clean cut. There's a very abrupt ending of the lacrimal sac. Another interesting point to note, the maxilla is missing. The nasal cavity is missing, the palate is missing. So this was a patient of maxillary sinus carcinoma, and an extended resection was done for this patient. That is why the nasolacrimal duct, there's a very clean cut there. So now in this patient, how do we find the structures? We're going to use navigation, and we're going to go endoscopically. So this is the endoscopic view of the same patient of the right nasal cavity. We can see there's no lateral wall, there are no turbinates, there's no floor, and even the palate is very deficient. If you look closely, we can see the endotracheal tube on the lower side because the palate is deficient there. So this is a video that is going to demonstrate how navigation was used in this patient. So we've marked our areas of interest in red. On the right side, we can see there's a blockage. On the left side, we can see the dye has reached the nasolacrimal duct and entered the nasal cavity. So one benefit of navigation system is that we can see this image in 3 dimensions in whichever way we want, inferiorly, superiorly, from the lateral sides, and we can plan the patient accordingly. So now these are the panels which we see. So this is real-time navigation in the axial, coronal, and the sagittal scans. We can see the probe that is approaching the lacrimal sac. And as we move the probe, you can see even the 2D images are moving. So we need to very accurately delineate the structure that we want to deal with. And when the probe will touch the lacrimal sac, now we see in all the three images there is a white round structure. So we've reached the lacrimal sac here. So we can also integrate endoscopy into the system. So instead of the 3D view, now we see the endoscopic view. So wherever we touch our endoscope, we can mark out where we are. And this particular system, this is a very interesting thing. This is called the look ahead protocol. So wherever our probe currently is, wherever our endoscope currently is, we can mark the trajectory. So in the 4 images, the first image shows the crosshair where the 2 green lines are joining. That shows our current location. The second image, that is the right side upper image, shows us 5 millimeter beyond the trajectory. So if we move in the same direction 5 millimeters, where we'll reach. The third image, the left side lower image, it shows 10 millimeter into the trajectory, and the last image shows 15 millimeters. So this is the look ahead protocol. So when we move our endoscope or our probe, we can see that there is a white structure appearing in the third image, that is 10 millimeters. So that implies if we move our endoscope 10 millimeters into the same pathway, we'll reach the lacrimal sac. So as the endoscope moves, the images also move. So 3D DCG has been utilized in stereotactic surgeries using what has been just discussed, and in the same patient that I discussed, the authors have published a case report. So all those who are interested to read up in detail to know the management can access it online here. Then another interesting case is the congenital arrhythmia with microphthalmia syndrome. This is a very, very rare syndrome with only 30 cases reported in literature. So in this patient, we see there's a young female patient who has microphthalmia, microcornea, and on pressing over the lacrimal sac area, there's a mucopurulent discharge. So this particular patient presented with a medial swelling on the left side. So this is the facial photograph of the patient. We can see she has microphthalmia. She has a visibly hypoplastic palate. And in the close-up image, we can see even the anterior nair on the left side is hypoplastic. So this is not a total arrhythmia, but a partial arrhythmia. And there's a scar on the upper lip that signifies there was a cleft lip also that has been repaired. So when we do endoscopy in this patient, in the image on your left hand is the left nostril, that is the arrhythmia nostril. We can see that there are no turbinates, there are no structures, and also if you look closely, there's a subtle perforation. So there's another globular structure that we can see, that is the middle turbinate of the opposite side. Then the image on the right hand, it shows the endoscopy of the right side, which shows a very large middle turbinate. This is a hypertrophied middle turbinate. So now in this particular patient, the nose has not developed properly, but the lacrimal system has been developed. So how do we deal with this case now? So a possibility for management remains that we make lacrimal sac flaps on the affected side and somehow we join it to the septum so that it opens into the opposite side. So these are the CT scans in the 3D reconstruction of the patient. We can see all structures very well on the right side, but on the left side we can see there are no ethmoidal air sinuses, no maxillary sinus. The maxilla is very hypoplastic, not well developed. Another interesting thing to note in this particular patient is that the frontal process of maxilla on the left side, it is directly attached to the frontal bone. So it is directly attached to the skull. CT scan of this patient also showed a mucocele, so we could accurately mark what are the dimensions of the mucocele on the left side. Now this is a computer generated image. The yellow rings, this is the intended pathway that the surgeon has marked in the system based on the patient's images. So in this patient, we're going to go from the left side to the right nostril, to the right nose. So whenever we move from our intended pathway, the computer will tell us that we're deviating from the path. So there comes the role of navigation again. And if we look closely just below this yellow pathway, we can see the subtle perforation in the nasal septum. So this is the same patient, 3D reconstruction of the patient, showing the intended trajectory that we are going to follow. So a combined external and endoscopic approach was used in this particular patient. An external incision was made, the soft tissue dissection was done, lacrimal sac was identified. But in this patient, we could not use the bone ronges further for making the ostium. So a bone drill was used. Because we saw the frontal process of maxilla was directly attached to the skull, so we could not cause much trauma to the patient. A bone drill was used to mark the ostium. And now this shows the probe passing through the lacrimal sac flaps. So before we touch the septum, it was confirmed on navigation in real time if the structure we're touching is really the septum or not. So the endoscopic image, it shows the lacrimal probe touching the septum, and in the other 3 CT scan images in all the 3 different views, we confirmed that it is the septum that we are touching. After confirmation, septal flaps were made. So these are the septal flaps. The probe is now touching the septal flap. And now the probe has passed through the septal flap. So now we've entered the opposite nasal cavity. But we saw that there was a very large middle turbinate in this patient on the opposite side. Now it is gone because middle turbinoplasty was also performed in this patient to create some space. So this is the nasal mucosa and turbinoplasty has been performed. After performing turbinoplasty, a Crawford stent was inserted and the lacrimal sac flaps from the left side were sutured to the septal flaps, so that a pathway was created from the left side opening into the right nasal cavity. These flaps were sutured and the wound was closed. So this particular case is also published online. Those who want to see the details can access it online also. The same authors have used image-guided decryolocalization in patients of trauma, patients who have complex mid-phase trauma. Navigation guidance is a very good option in such patients also. So to conclude, complex nasolacrimal duct obstruction is increasingly common now because we are able to recognize it better. We are able to assess these patients better now. So before we take up the patient for surgery, a meticulous clinical examination should be performed. There should be a good preoperative planning for the patient, and navigation guidance is a very good tool in such patients. But the surgeon should also keep in mind the 3-dimensional anatomy, the normal anatomy and the abnormal anatomy of the patient. So navigation is a very important aid, but it cannot replace the surgeon. And with meticulous planning, with use of navigation, we can have fruitful outcomes even in the most complex cases with good final results. Thank you.